Conference, the health workforce of the future and its regulation. And of course, Dr. Letlhapa has also provoked us to say, as we talk about the future, I think very important point that sometime when you talk about the future, you want to throw away, as they say, the baby with the bathwater, even the good things of the past. So as we talk about the future, as we said yesterday, that it's important to talk about technology and all that, but at the same time, let's not discard the good practices, those which we learned and the fundamental practices which have kept us going. So I will touch on some of the experiences of the last 2 years and just go into some of the areas which the sub-themes of this conference. Now, the healthcare workforce is indeed very fundamental to the attainment of universal health coverage and the health of our people, as well as very fundamental in building a health system with capacity, which is also inclusive of making sure that our economic growth grows. I think if anything, COVID has taught leaders of the world, leaders, heads of state, and right up to the United Nations, that health is not just an expenditure, but it's an investment. That if you don't look after the health of the population and you think because it is just an expense, it can bring down your economy, as we have seen. This has become increasingly evident over the last few years as countries at all stages of economic development have witnessed the invaluable role of healthcare, especially the health workforce, as well as the immense challenges that we face in this area and the impact that this has on the workforce itself and the system. The economic stress resulting from COVID-19 pandemic and lessons we have learned from other previous economic downturns has demonstrated that in order to build a better health system capacity, we need to spend on health even during difficult times, even during economic crisis. We must, as I've said, look at health as an investment and not just as an expenditure, and that's really the message we must always preach to those in power. The building back better of health system in the context of the pandemic recovery presents the chance for all of us to transform our health services delivery and the workforce models to be more efficient, enabling, and also making sure that we look after the well-being of the workforce itself. We have seen how the benefits of rapidly evolving digital technology, including telemedicine and e-learning, have begun to be realized, and the availability of critical technical guidance and tools are enabling countries to collect, to access, and also to share health and health workforce data and other information, which is very key to policymakers. So technology, as we have indicated as one of the themes, has indeed played a major role in our ability to manage this pandemic. In the South African situation, our demographics shows that the population is changing with a growing middle class, and with the trends which then put pressure on our health services in the coming decades. It is estimated that by 2050, South Africa is expected to have grown its population by over 15 million. And about 77% of that population will have moved into the cities. In fact, we already witnessed that. Just as you look, just as an example, the Gauteng province, which is your big metropolitan province of this country, just over 10 years, have grown its population by almost over 5 million. Just over 10 years ago, the Gauteng population was under just around 9 to 10 million. But as we speak now, because of its metropolitan nature, through internal migration, it has grown well over 15 million people. Economic growth will help to expand the middle class, especially in these urban areas, and hopefully we'll be able to, at the same time, reduce poverty. But a lot will have to be done to reach the SDG goals of 2030. These demographic shifts will lead to also increase in age-related non-communicable diseases. As the population also will be aging, although currently we do have a huge youth bulge, but as the economy hopefully improves and we get more older population, just as is the case in developed countries, it means that we also have to be ready for an increase in non-communicable diseases. Therefore, we'll have to be, our health systems will have to be ready also to respond to this kind of challenges. At the same time, we are expecting that our life expectancy will be improving. Our target in terms of our national development plan is that by 2030, the average life expectancy of South Africans should reach 70 years. We have suffered a bit of, going back on this. We are already at an average of 65 years, 66 years, but as a result of the pandemic, we have made some losses in this regard, but we're hoping to catch up. But we're hoping also that beyond, first of all, we must reach our National Development Plan targets. And hopefully beyond that, we can even improve if we can manage some of the diseases, like the infectious diseases like HIV and AIDS, which are dragging this life expectancy backwards. Due to out-migration of youth, many rural people will be both poor and elderly as more of the younger people move into the cities. And at the same time, we also see the migration of the health workforce from rural to urban areas, which is something which we touched on yesterday and which we must manage to make sure that the distribution of health workforce is also not skewed against rural and poor people. So in this regard, we have engaged the digital health technologies to improve the quality and coverage of healthcare in terms of making sure that we can increase access and also skills and promote positive changes in the behavior of how we manage our systems. And this has been, again, very evident in the management of the COVID-19 pandemic. We have been able to make use of the proliferation of mobile devices, which helped us to spread a lot of health messages. This also combined with emerging technological advances, such as the scene which we have reflected here of the digital health, to make sure that it can have a very positive contribution in improving the quality of our services. It's incumbent on us to make sure that the digital technology can transform the way in which we provide services, but also as the population becomes more and more informed, expectations also will be much, much higher. The widespread availability to access to information can also, as I've said, increase expectations of, in terms, people become much more informed in terms of what kind of services they should expect. Now, this access to information it's a very useful tool in terms of enabling the population, but we have also learned, as we've been managing this pandemic, that it's good in terms of spreading positive information, but it is also available for negative information, for fake news. Also, as we have seen, when we rolling out the vaccination programs, we see that also, on the other hand, those spreading negative messages about the impact of vaccines have also made use of this technology. So what is important is that from our side, as the health professionals and the health providers, we must make more effective use of the technology. Now, in this context, one will look at some of the implications of some of the sub-themes which we will be reflecting on during the course of the next 3 days. In the area of reforming training and education practice, coming back to the use of technology, the COVID-19 pandemic has forced us to use technology also in teaching from basic education right up to higher education, including the training of health professionals. Now, even though we are very optimistic that we are at the tail end of the pandemic, I believe that we must make positive use of some of these experiences of how the use of technology has enabled our health education institutions, even at the times of hard lockdowns, to be able to proceed and make sure that we can still produce health professionals in the same way as also at the basic education level through remote teaching. This has helped us to navigate our way through the pandemic, even at the hardest of lockdowns. So we must continue to see, as we transit from the pandemic, those positive lessons. How can we use the technology in making sure that we can improve and expand access to health education at the basic training, and also at the specialist training, but also how we can use this experience in terms of continuous education, continuous medical and professional development. These are the tools which I believe that we must retain. In our country today, when we look at the medical schools, we have 9 accredited medical schools. And out of this, 7 can be classified as urban. That is University of Cape Town, Stellenbosch, Nelson Mandela University, which is recently accredited as a medical school, the Free State, Wits, and University of Pretoria. This I would want to classify as more urban medical training institutions. And then we have got 2 which can be as rural. That is the Walter Sisulu University in the Eastern Cape, and also the Limpopo University. Now, the 2 rural universities are in a perpetual struggle to attract experienced and highly qualified teaching specialists and professors. This is made worse by our current policy in what is called remunerative work outside the public service. In short, here in South Africa, it's called RWAPs. Very difficult matter to manage, not very useful in terms of making sure that we can provide good quality services, but also even in terms of training. So the more lucrative opportunities in the cities with many high-income private patients, and also a proliferation of private hospitals, become more attractive in terms of your your highly experienced specialists who we require to provide teaching, and therefore our rural medical schools struggle in this respect. The question then is learning from COVID and leveraging on the use of technology. How much can especially our rural medical schools leverage on this use of technology to access knowledge and skills, including of those academics who are reluctant to move from the urban areas into the rural areas. Some few years ago, we had a very difficult situation where there was an attempt which later on we had to reverse, where one of the medical schools, the Sfakomahatu, previously Medusa, in some reconfiguration was then reconfigured into being a medical school of a rural university, the University of Limpopo. And what we experienced at the time was that it started losing some of the highly experienced academics. And what was the main driving problem? The fear of going to a rural area. So these are some of the challenges which we have to deal with. And the question then which I'm raising is, because this is going to be continuing, and I'm sure in other countries as well, as you expand your services and as you want to also expand even training into rural areas, you will find that the question of attracting your highly qualified professionals into those rural institutions is going to remains a challenge. And I'm saying that from the experience of how we navigated at these various teaching institutions, COVID, using technology, is there in there maybe an answer to some of the challenges which our rural medical schools are facing? And not only, I believe, in terms of training of doctors, but in terms of the training of other health professionals as well. The other essential in the reform of medical education is in the context of what we have been talking about for many years, but in terms of actual implementation, very slowly, transforming from hospice-centric, urban-centered medical and health training to a more primary healthcare oriented and including decentralized teaching, including using rural platforms. These are some of the reforms which we need to drive, and in this respect, I believe again that technology can be a very critical tool in realizing our aspirations. We must also transform from individual-centered training skills into team-based healthcare professionals, because I believe that as we move into the future, we must emphasize more on healthcare team rather than as a healthcare individual professional. These are some of the areas which I believe we need to be looking at. Moving from there, more than just the teaching, how else we can leverage on the use of technology. It's also emerging, the use of technology is also emerging as a game changer in terms of the point of care, clinical services. We now have the tools through which laboratory and radiological results and other clinical information can be interpreted far from the actual point of care and from where the actual tests have been performed, and be relayed back to the area where the tests were done. So with all these tools available to us, it means that even we know that currently even very complicated procedures can be done with participants from the actual area through the digital platforms, through cameras. Very complex procedures can be done under supervision, not necessarily physical supervision, When I was working in one of the rural hospitals in one of our areas in the Mpumalanga area, we relied quite a lot, and whenever you had a complex case, you have to now refer almost sometimes 400 to 500 kilometers into the big cities. The question is, as we want to reduce this gap currently, can we be able also to use technology in making sure that even those who are providing services in far more remote rural areas can do a lot of even complex procedures under supervision from those who have more experience, even if they are based in urban areas, under support using technology. And I believe that with the current advancement of technology, this is feasible. The other simple use is in terms of digital technology is our improvement of our health information systems. I know that we're still struggling in terms of in our country in making sure that our health information can be fully digitized and be accessible irrespective of where a patient presents. We are currently working on the various steps to improve our health information systems, and hopefully some of the gains from COVID, such as the digital platform which we created for the vaccination program, can be transformed into a more broader health information system, so that when the patient pitches up in any part of our country, whether it's here in the northwest at the Moses Kutane Hospital just across from here in the Mohase area, or whether the same patient pitches up in other parts of the country, in Cape Town, you'll be able to share the same information. And I believe going forward, if we are successful, it can even mean that if we can integrate our systems in the continent, it can mean that, Minister, if I pitch up in Namibia, if the technology, we are able to integrate our technologies, you'll be able to, the doctor in Namibia or in Uganda can be able, through the technology, be able, even if somebody is unconscious, if you just have their passport number and so on, I think the technology is there. The question is, how do we make sure that we can transform it into, becoming a tool which can integrate not only our countries, but also in terms of also integrating our continent. We did touch yesterday on the topic of the distribution of the health workforce. Now, all of us, I believe, from our countries and our region and continent, we're struggling with the same issues. Our highly qualified professionals prefer to, as I've touched on earlier on, to be in the urban areas because of reasons already touched on. But also within countries as well, we struggle in terms of retaining, it's not only the issue of training, but also in terms of retention. So there are a lot of things which we need to do in terms of, it's not just regulation. Some of the regulations do help, like in our case, by introducing community service for health professionals, we have been able to improve the distribution even into rural areas. But that's only limited. Like in our case, it's only a one year of community service. But what it means is that we need to have much more incentives in terms of the working conditions across the country must be such that once people are introduced into some of the rural areas, they find the working conditions conducive enough, but also support in terms of, again, continuous professional development, and also in terms of, it's very frustrating if you are, in the remote area and you have particular challenge in terms of providing service to your patients and you just don't have any support. So these are some of the things which we need to include to make sure that, but also just living conditions. Make sure that also in our rural areas, because some of the things which drive people out, access to good quality education, access to just basic tools such as the internet, social amenities. So if we improve working conditions, but also just social living conditions, we will be able to retain our professionals also in our remote rural areas. But I want to also raise to the regulators to say, just using the example of the community service, can we also make it a requirement? Training specialists is a very costly, exercise, costly to the taxpayer. Can we look at maybe together with, in our case, we also have the College of Medicine. I'm sure it will be the regulator and the college. Could we be able to introduce a requirement that for any specialization as a registrar before you can sit for your exams, there must be a minimum period which you must spend outside your urban centers. If it's a 4-year postgraduate, there must be a requirement that part of your rotation, a minimum of at least a quarter of that, must be in a designated under-serviced area. I want to leave that to you as regulators, that these are some of the things which you must consider. You've also, on your themes, on your sub-themes here, the issue of the health workforce wellness. I think, if anything, again, COVID-19 has reminded us as health authorities, we must not take for granted the health and wellness of our health workforce. Many of our health workers, have been devastated, not only in terms of the pressure of work, but also mentally very, very demanding. So it is up to us to make sure that that our health workforce is protected, provided with the right tools, the personal protective equipment, but also the tools of work, that they have the relevant tools for trade, social support in terms of transport, but also psychosocial support. This is one of the areas which we are being reminded that as we come out of the high levels of the pandemic, that many of our
Although you heard it, COVID has reversed the gains in the life expectancy space in South Africa. The Minister of Health, Dr. Phaahla, they're talking about the future of the healthcare sector and regulation in this space.